So I have two back-to-back talks. So I'll cover both. Use of PEEP in different diseases. What is PEEP? How do you set it? How often it is abused or misused by us? And what is the learning we're going to get from it? And waveform analysis, which I'll do after that. So positive and expiratory pressure, good or bad? It is both actually. Good for some, bad for some. The trick is to know where is it useful and where it is not. And we will also discuss how to set PEEP in ARDS, whether the low PEEP strategy is better or the high PEEP strategy is better, and how to set the optimal PEEP. So what do you mean by optimal PEEP in the first place? COPD and asthma, how to set the PEEP here, and morbid obesity. So effectively, PEEP has a multifaceted effect. It has a good part and it's got a bad part. The good part is obviously the role of PEEP is to increase the mean alveolar pressure, hence cause alveolar recruitment, increase the functional residual capacity, improve the oxygen reserve, and thereby reducing the hypoxic vasoconstriction which is there because of any disease process. By reducing this hypoxic vasoconstriction, it's going to reduce the left ventricular outer load, and it also decreases the ventricular transmural pressure gradient. So for a patient with left ventricular failure, PEEP is good, because what do you need to do? You need to reduce the preload, reduce the afterload, improve the contractility. Right? This is what you want to do in LV failure. What does PEEP do? Reduce the afterload. So it is useful. At the same time, it's going to cause over-distension of alveoli, because there is non-homogeneous distribution in ARDS. Some alveoli are fully open, some of them are partially collapsed, some are fully collapsed. Giving high amount of PEEP may not open up the fully collapsed alveoli, but can cause over-distension of the alveoli which are already open. So this leads to increase in what is called zone 1 phenomena. Anybody understand what zone 1 phenomena is? Yes. Alveoli, capillaries, it's like a bunch of grapes with a capillary network around it. Over distension of the alveoli will constrict or press the capillaries. So effectively there is a VQ mismatch. Ventilation is increasing, but the perfusion has been paradoxically reduced because it is because of over distension of the alveoli. So you do see that the patient's saturation sometimes starts to fall once you start giving high amount of pressures, and once you disconnect from the ventilator, suddenly the saturation also improves, the blood pressure also improves. So this is a zone 1 phenomenon. It causes vascular compression within the thoracic cavity, will impair venous return, will reduce the right ventricle and left ventricular preload, but at the same time will increase the pulmonary vascular resistance. So it increases the right ventricular afterload. It reduces the left ventricular afterload, but it increases the right ventricular afterload. By increasing the right ventricular afterload, it is deleterious for which side failure? Right heart failure. It's because the preload to the right heart is reduced because of the increased intrathoracic pressure. The venous return is reduced. Venous return is again some gradient from higher pressure to lower pressure. If the pressure in the thoracic cavity is high, the venous return will be hampered. So since it reduces the venous return, the preload to the right heart will reduce, and subsequently in series the cardiac output will reduce. So the net effect of PEEP will depend upon a balance between over distension and recruitment. With this thought, patients with unilateral disease, right? Unilateral disease, whenever we hyperinflate one lung, the healthy lung is the one which is going to get hyperinflated, right? The diseased lung with the alveoli already flooded is not going to get hyperinflated. So paradoxically, what you're going to do is you're going to divert the blood from that healthy lung towards the diseased lung, because you have caused over distension of the healthy lung. So very high amount of PEEP in unilateral disease is not a very sensible idea. Get it? Unilateral pneumonia, you don't go about PEEP of 15, 20, it won't help you. Eventually what it's going to cause is going to cause further diversion of blood into the infected area and cause more shunt. So that really won't really help you. Sorry. ARDS, the classical or what is called it, like the model which has been described is there are areas which are aerated. They are partially recruitable areas and are totally collapsed areas. And the safe window is to recruit the area which is recruitable, right? And that area is supposed to lie between the upper and lower inflection point. So PEEP in ARDS up to a specific level is good, beyond a specific level is dangerous. So that's the reason why this strategy was proposed, that we should have an open lung ventilation strategy, first described by Amato, where it wanted to use PEEP to overcome the lower inflection point and allow ventilation between the upper and lower inflection point. The more alveoli you recruit, the better is the oxygenation. That is the concept behind it. But how do we get to this? We'll come to that. So, in ARDS, we talked about pneumonia, too much PEEP probably not useful. In ARDS, it's a bilateral disease, it's a non-homogeneous disease. Okay, how does PEEP help? PEEP will maximize recruitment of alveoli. Secondly, it prevents recurrent closure and opening of alveoli. Right? If you keep the alveoli distinct, what's happening in ARDS? The alveoli are getting flooded. The surfactant is lost. Since the surfactant is lost, the reason for the alveoli to keep open is also gone. Since that is gone, they tend to collapse in exhalation and in expanding inhalation. So this opening closing of alveoli which occurs leads to shear stress. So there is shearing and there is further destruction, further flooding of the alveoli, and this is a vicious kind of a cycle. And this leads to biotrauma, that is release of inflammatory markers, and a disease which was probably an end result of some other disease. ARD is always a secondary phenomenon from some other disease. And that will become a systemic problem. So the high and PEEP table, I'm sure all of you are aware of this. This was given in the ARDS clinical trial network, which gave you a PEEP and FiO2 combinations, and they sort of graded it into a high PEEP and a low PEEP group. This is available everywhere, so I don't really need to go this. But did high PEEP actually help? The answer is somewhat, but not in mortality. High PEEP did help in improving oxygenation, increasing ventilator-free days, decreased need for rescue therapy. And especially in the subset of patients with a PF ratio of less than 200, so moderate onwards, who were mechanically ventilated using a high PEEP strategy, had a lower ICU mortality. This is JAMA 2010 meta-analysis. But again, is high PEEP actually safe? So this is a study on the stress and strain dynamics. Now what is strain and what is stress? Okay, I'll put it in a much more simpler way. Which is a volume phenomena, which is a pressure phenomena? Stress volume or pressure? Strain is volume phenomena. Strain means the stretch of the alveoli. The stress is the amount of pressure which is required to stretch that alveoli. So strain refers to a volume kind of phenomena. So it has two parts, a dynamic part which is a tidal volume which is coming and going with every breath, and a static part which is a PEEP which is going to keep the alveoli distended at a specific volume. So the total strain will be a combination of the static and dynamic. The conclusion by this is that you can use higher level of PEEP, but you have to adjust the tidal volume accordingly. You cannot have a tidal volume of 8 to 10 ml per kg and give a PEEP of 20, 15. That's going to be disaster because you're going to increase the strain. So the strain also plays a very major role in biotrauma, atelic trauma, volume trauma. So the strain aspect, we are focusing on the stress, we are focusing only on the pressures, but you should focus upon the strain as well. So if you use high PEEP, consequently your volumes should be 6 ml per kg or less. It's not that you can go beyond that. A combination of alveoli, love and express trials, there will be three major trials which compared high and low PEEP, and you see that there was no significant change in mortality values. The last table there, the P values were not exactly significant, and low and high PEEP had similar kind of mortality range. The only thing it did better was improved oxygenation. So who benefits? No mortality improvement, 10 millimeter improved oxygenation, and those patients whose PaO2 actually increased with PEEP improved mortality. Even in that subset, only the recruitable patients were the ones who had a mortality benefit. Those whose lungs were not recruitable had no mortality benefit, because if PEEP could not recruit, it's going to cause harm. It's like two-edged sword. If it's not going to recruit, you're just increasing the amount of strain in the lungs. So one has to make sure that the lung is recruitable. And how do you assess recruitability? And improvement in PaO2, sequential series improvement. The second question which you want to know, everybody says plateau pressure 30, plateau pressure 30. Why this plateau pressure 30? Is plateau pressure 30 the target value? In a rough kind of a way, or for the message to percolate across the entire globe, we can select a target of 30, because not all ventilators, we cannot measure transpulmonary pressures that effectively. What we are trying to target is trying to actually limit the transpulmonary pressure. Effectively, that's what we are trying to do. But we are using plateau pressure as a surrogate. But actually, plateau pressure is a surrogate of transpulmonary pressure. To a lot of extent, it has a correlation. But in this few subset of patients whose chest wall is very heavy, malformation of chest wall is there, extremely obese patient, extremely thick chest, high intra-abdominal pressure. So those patients, because every time we consider plateau pressure, we are considering that is the plateau pressure of the entire respiratory system, including the lungs and the chest wall. We consider the compliance of the chest wall is absolutely fine. But no, the chest wall does have a role, especially in this subset of patients where the compliance of the chest wall itself is poor. Large pendulous breasts, very heavy patients, or patients with a tense abdomen, abdominal compartment syndrome. Here, the plateau pressure target of 30 may not be enough to ventilate a patient at all. For example, if you say 30 is a dangerous limit, the patient who is playing a trumpet, alveolar pressure goes up to 150, right? The alveoli should burst, but it does not burst because consequently his pleural pressure also goes up to 140. So the difference of the transpulmonary pressure still remains 10. So he is generating extremely high intrathoracic pressures, but there is no damage being caused because the transpulmonary pressure, which is the measure for damage, if I can say it like that, that is in a safe range. Similarly, patient with a stiff chest wall, an alveolar pressure of 30 with a pleural pressure of 25 will still have a transpulmonary pressure of only 5. So what is the measure which you would really like to see is the pleural pressure. Effectively, you would like to measure the pleural pressure by some means. But that's not very easy to measure. So transpulmonary pressure, which is, what is transpulmonary pressure? Between and pleural pressure. Okay, fine. If the plateau pressure is more than 30, then and the patient is not getting ventilated at all, and you're suspecting it's because of poor chest compliance or all those reasons which I told you, you have to have some measure of transpulmonary pressure. If it's less than 25, you can go ahead and increase the PEEP further without fear of causing strain or further damage. If it is more than 25, then the lung is not recruitable per se, and probably you'll have to go in for some alternate means of ventilation, that is probably going on to an ECMO. So it's a transpulmonary pressure which should be limited rather than just the plateau pressure. That is the take-home message which I am trying to give you. And how do we measure the pleural pressures? By esophageal manometer. Yes. So the esophageal manometer at which stage? Inspiratory, expiratory? All measurements are end expiratory. Okay, at the end expiratory, an esophageal manometer will closely relate to the pleural pressure. So you can get the difference between the alveolar minus pleural, and that is your plateau minus pleural pressure, that is your transpulmonary pressure. Now another concept, driving pressures. Okay, so what is driving pressure? Repeated with every opening and closing. So it is given by the formula of. Okay, so what it says that higher PEEP, which I have already told you, only in patients who are responders. Who are not responders, PEEP is counterproductive. So by increasing the PEEP, if the driving pressure is decreased, that means the compliance is improved, right? So the plateau pressures have come down, so the driving pressure has decreased. So the driving pressure has decreased, that means there is more recruitment. more space for the air to relocate to different parts of the lung, so better lung mechanics. At the same time, PEEP is increasing, the driving pressure is increasing. How much do we target the driving pressure? Which is the figure which is quoted? Less than 50. Let's have a figure which is 12 is desirable, but rarely do we try to achieve it in the average, we may never get it. So less than 15. So if the driving pressure is increasing with increasing PEEP, then there is possibly overdistension. So this overdistension concept is very important because this is something which we neglect. Overdistension leads to decreased venous return, decreased to increased strain on the right heart, leads to zone 1 phenomena, leads to further worsening of hypoxia, further worsening of hemodynamics, and the entire vicious cycle. The patients who are borderline will have acute cor permanente, and then that can be a disastrous condition for you to ventilate. So how do we take out the optimal PEEP? We have said between upper and lower inflection point. That's a vague term. How do we do it? And we try to keep the pressures 2-3 centimeters above the lower inflection point. So the problem with optimal PEEP is that there is no agreed upon method of determination, and it may change over the period of time because your lung condition changes over a period of time. It may improve, it may worsen. So your optimal PEEP will also change with time. The best PEEP may be actually independent of oxygenation effect because hyperinflation, the same PEEP is causing hyperinflation, it can cause further injury. At the same time, best PEEP can be independent of respiratory mechanics as well. So how does the ARDS split says? It says escalation tables. Adjust PEEP to maximize the static compliance, that is trial volume by plateau minus PEEP, that is the driving pressures. Set the PEEP slightly above the lower inflection point. Use a stepwise or a staircase method for recruitment to find the lowest PEEP at which the maximum oxygenation is achieved. You can use a transpulmonary pressure calculation from the esophageal manometer and adjust PEEP so that the transpulmonary pressure at end expiration is between 0 to 10. Just remember the figures, 0 to 10. You can also use electrical impedance tomography, and these are going beyond the range of what else. If somebody is constantly asking you silly questions and what else, you can always say electrical impedance tomography. I'm sure they would also know what is electrical impedance tomography. Okay, so I'll tell you in a nutshell in case somebody wants to ask you further what is that. So whenever there's increase in aeration, the impedance of the impedance increases, right? So that will show us different colors in the electrical impedance EIT monitor, and that screen it will show different colors, and it will automatically tell you increased recruitment, de-recruitment, recruitable lung, non-recruitable lung, and so on. And if you are lucky enough, Gatineau need to have a CT on the bedside, and you can always do a CT and see what is the best thing. Esophageal pressure measurements are available now, manometers are available here. So this subset of patients which I mentioned to you right at the start, where the chest wall compliance or the abdominal compliance is doubtful. In that subset of the patient, you may actually require higher pressures to keep the lung open. And just limiting it at 30 or arbitrarily going into 35, 40, 45 doesn't make a lot of sense unless you are backing it up by some kind of calculation. So we already spoke about the esophageal, and pressure is a surrogate for pleural pressure, and we use it to guide it. To some extent, ultrasound can also guide to some extent, not very reliably, because ultrasound cannot see overdistension. So overdistension is something which you cannot find in ultrasound. So be very careful when you try to recruit with ultrasound. But it can give you a guide to which patients are actually recruitable. Let me put it in a different way. How to recruit is not the thing which you're going to do with ultrasound. Which patients are actually recruitable is the sensible question which you need to answer. If you have a patient of ARDS with a predominantly posterior distribution of your collapse, consolidations, and so on, then giving very high amount of pressures or a high PEEP strategy really won't help much. Why? Because a totally collapsed area really does not open, but the high pressures will be transmitted to your upper or the anterior alveoli, which are going to get over distended and going to cause further trauma. So what do we do with these patients? Let them die? No, these are the patients whom you will make prone. Right? So they are going to just reverse the entire thing, and that is going to benefit this subset of patients. So patients with predominantly posterior disease, proning is a good option. Patients with global uniform disease, more anterior, less posterior, or generalized, here a high PEEP strategy can be gone and you can use. So this is how it sort of suggests to you that this patient may benefit from proning, this patient may benefit from a high PEEP strategy, or this patient may benefit from a low PEEP strategy. Stress index. Now this is also something some people like to ask. I don't think anybody uses it, but people like to ask. A tool to monitor recruitment and overdistension. And how is that tool? In a volume cycle mode, wherever the flow is constant. I'll talk about flows and curves in the next one. So whenever the flow is constant, so all the changes in the pressure time curve, we're going to look at the pressure time scalar. Okay, the pressure time, this scalar which is right on the top. Pressure time, then flow time, then volume time. These are the three scalars which you see on your screen. So the pressure time is right at the top. The changes in pressure time scalar will depend on the change in compliance. Okay. Prerequisite, the patient be sedated or preferably paralyzed. It's a constant flow condition and it's a volume cycle mode. So this is the graph of the pressure time scalar which we get. The lower one, upper one is flow time because it's a positive and a negative reflection. Lower one. If you see the lower one, you see that the three graphs look different. Let's talk about the graph right in the middle. The stress index where it's a straight slope upwards to the peak inspiratory pressure. If there is a uniform slope, then the stress index is considered to be 1. If there is a upward curvature or a concavity downwards, as you see in the first one, the stress index is considered to be less than 1. This is suggestive of recruitability or overdistension. Are you sure? Who says recruitability? How many say overdistension? It's a recruitability. Okay. And the other one, which is scalloped downwards. Okay. Stress index greater than 1, that has a different meaning. Right. So potential for recruitment, overdistension. Right. Let's put it in a very simple way to remember. Recruitment means फूलना, ये फूल ही तो रहा है, ठीक है? तो फूल रहा तो recruitment. That is overdistension. बाकी चीजें दब रही हैं, नीचे जा रहा है, दब रहा है. Easy to remember. Okay, so let's just go ahead with this. Let's not go this. This is the conclusion. Again, we are saying the same thing again. Let's not talk more about this. Now, what about PEEP in prone position? Should we go for a high PEEP or should we go for a low PEEP? Yeah. Any inputs? High or low PEEP? No. The idea, I told you, which are the patients you are proning in the first place? The ones with the predominantly posterior disease, where you are trying to avoid high PEEP in the first place. So they were not going to benefit much. So the beneficial effects of prone position is based on redistribution of ventilation but maintenance of perfusion. You agree? Agree, right? The ventilation comes upwards to the more dorsal areas of the lung because dorsal becomes superficial. Perfusion remains the same. Now, what happens when you give very high amount of PEEP? The blood is diverted away from the areas of perfusion because of overdistension and so on. So we don't want to redistribute the perfusion. We want to maintain the ventilation and maintain the perfusion the same level. So in prone ventilation, redistribution of perfusion should not be attempted by giving very high amount of PEEP. So we should sort of limit the amount of PEEP when you talk about prone position. Okay. So avoid supraphysiological PEEP may be less beneficial, potentially harmful in patients with prone position. Giving prone position 20 PEEP, no, really not. Especially at the same time you are trying to dehydrate the patient, get extra fluid out. Your volume contracting, these capillaries are going to immediately go into zone 1 as soon as possible. So let's not do that. The next thing, phenotype-based approach. This is the new thing, which is a lot of interest in that, because they understood that just like we are all different, the ARDS is also all different. Okay, so there's a hyper-inflammatory phenotype which has got higher inflammatory markers, patient who appears more higher SIRS, more septic, more hyperdynamic circulation, everything. Here, a higher PEEP strategy, a conservative fluid management is useful, because more SIRS means more leaky capillaries, more leakage into the lungs, right? Effectively. So here, higher PEEP will keep that alveoli dry, will keep the fluid out of the alveoli, and fluid restriction will help in reducing the leakiness of the capillary. It makes sense. Where the hypoinflammatory phenotype may not benefit from high PEEP strategies, they may actually get worse. Okay. If you ask me how to find out which is this phenotype and that phenotype, it is based on clinical picture. Patient who is hyperdynamic appears obviously septic, high inflammatory markers. Such patients with extremely rapidly worsening axis, such patient may be the hyperinflammatory phenotype, right? And they may be benefiting from a restricted fluid strategy and higher PEEP strategy. So the factors to consider: severity of hypoxemia. It is beneficial in beyond moderate ARDS. It is most beneficial. There is no sense in giving high PEEP to mild ARDS. Doesn't make any sense. Focality of the disease. Unilateral disease, probably no great idea of giving very high amount of PEEP. Cardiac function and intravascular volume assessment. Left heart failure, useful. Right heart failure, be very scared. It's giving very high amount of PEEP. Context of illness. High inflammatory markers, possibly high PEEP, fluid restricted strategy. Obese patients, compliance is something which you need to keep in mind when you talk about plateau pressures as a limit. CHF, high PEEP, definitely would help. And choose empiric setting, assess the delta P, blood pressure and saturation. Every time you try to recruit, you have a look at these measures. Coming to COPD, now let's speed up a bit. COPD. Now COPD is different from asthma. How is it different? There is what's called, there is dynamic hyperinflation, is there in the expiratory flow limitation. That is the word everybody wants to hear. Expiratory flow limitation present in COPD, more or less absent in asthma. So the expiratory flow limitations occurs because of remodeling of the entire lung. The entire lung is remodeled, there is loss of the tethering network, and that's the reason why there is a collapse during normal expiratory phase itself, right? So there is an expiratory flow limitation, or a waterfall effect which you call it. So you need to have some amount of PEEP to distend and keep the alveoli open, the airways open. So this is the cycle of COPD exacerbation. Increased drive, mechanical disadvantage, hyperinflated lungs, flattened diaphragms, really can't do much, neuromechanical coupling, and this adverse effect of hyperinflated lung on the venous return, on the right side of the heart, on the left side of the heart. And all this leads to anxiety, further tachypnea, further worsening, further air trapping. Dynamic hyperinflation is the phenomenon where the expiratory flow is not emptied, hence the resting FRC to the resting FRC value. So there's some amount of air trapping which is occurring with every breath. It is seen normally when you do forced expirations in asthmatic patients, COPD patient, and also in agitated ventilated patients who are breathing at a very high rate. So you don't need to be definitely asthma COPD. If you are breathing at the rate of 35-40, you will have some amount of air trapping. And ARDS patients with low tidal volume and a high rate, these are certain patients where you have dynamic hypertension. What are the factors which cause increasing resistance? So the resistance affects you during the inspiratory or the expiratory phase. It affects actually both, but it is more during the expiratory phase. Why? Because exhalation is passive. Everything else is being pushed into your lung, but exhalation is passive. That's where the resistance plays a maximum amount of role. So there's acceleration of gas from multiple small airways to a few larger airways, and the transition from laminar to turbulent flow. Right now they have diverted the road from Delhi to Gurgaon, so the 4 lane has become small, so everything becomes turbulent flow there, and I'm taking 1 hour to reach every day. So there's one more word which I mentioned: differential time emptying of alveoli. What is that? There's something called alveolar time constant. What is that? What is time constant? how many percentage of the alveoli to empty out? It's what a percentage of alveoli. Around 80% of the alveoli to empty out, that is a time constant. And how much the expiratory time will be? How many times the time constant? That's twice a come here. Yeah. So we try to keep the expiratory because different set of alveoli have different time constant. The time constant is because our alveoli are individual units and each of them will emptying at a different rate. So you want to keep the expiratory time at least 3 to 4 times higher the time constant so that you make sure the majority of the alveoli at least are emptied out and there is no air travel. Okay. So why does hyperinflation occur in COPD? I told you, airflow limitation, there is loss of tethering network, so there is passive collapse during exhalation and this leads to increased expiratory resistance. There is no time for complete expiration of the lung volume because of either higher respiratory rate or a higher tidal volume, both the cases, and because of the force in which the patient is trying to exhale out, because his dyspneic, tachypneic is trying to exhale out, and this expiratory muscle activity can elevate your auto PEEP measurements also. So the auto PEEP should ideally be measured in a totally sedated patient. That is the best measure of auto PEEP. How do you measure the auto PEEP? By setting expiratory pause. Yes, expiratory pause in a relatively sedated patient. If they are making active expiratory efforts, then the auto PEEP will be falsely elevated. That's what I told you in the previous slide. So the expiratory pause allows the different alveoli with different time constants to sort of open up. That much time it is giving. So whatever is trapped within the alveoli will come out. It will increase the pressures, and that will be your amount of auto PEEP that you have. And there's a lot of regional variation. There may be some which are overinflated, some which are underinflated, some may be more obstructed, some may be less obstructed. And the auto PEEP is an average auto PEEP. Let me put it very clearly. So average, it is not exact measurement of your auto PEEP in the lungs because of different time constants. So it always underestimates the degree of hyperinflation. Whatever auto PEEP you get, it's always an underestimate. The original value is much more higher. How does it affect you? Because of auto PEEP, the inspiratory threshold or the amount of work of inspiratory work of breathing, triggering work of breathing which you require is much more increased. Increased effort to trigger the ventilator, and this is the waterfall phenomena which I was telling you about. So if this middle area is blocked, how do we keep it open? By giving some extrinsic PEEP. This extrinsic PEEP is going to act like a stent. It's going to open up this collapsed area of this airways, and that extrinsic PEEP should be set at how much of the auto PEEP? Why not 100%? I just told you in the previous slides. Because it's 80%, what? Because it's always an underestimate. You don't want to keep it equal. It has to flow from higher pressure to lower pressure, right? You just want enough. There has to be a pressure gradient. So you have to have a pressure gradient for the air to alveoli to empty out. So how does this extrinsic PEEP, which is 80% of the auto PEEP, help? It reduces the trigger work of breathing. So when is it useful now? Is it useful when I have intubated the patient and put on ventilator? Or is it useful when I am trying to get the patient to breathe by himself and wean the patient? Yes. Now you understand why it is important during weaning. That is a phase where it is actually important. What about asthma? There is no expiratory flow limitation. So, and the site of increased resistance is more central. It is in the non-collapsible cartilaginous airways. The distal ones are non-cartilaginous. That's where the tethering network is lost in COPD. More distal. Emphysema, the distal network is lost, which are non-cartilaginous, pliable. They are the ones which collapse. Here it is more central where the cartilage is still there. So it's because of mucosal hypertrophy and increased secretions and plugging. That is a major cause of increased resistance in asthma. So there is no expiratory flow limitation or active collapse during exhalation. So there is no point of giving an extrinsic PEEP to overcome it. But when the patient starts to breathe, You can give slight amount of PEEP to increase the triggering effort. You don't always have to keep them at 0. When you talk about COPD has this constant collapse in throughout, whether the patient is totally controlled or patient is breathing spontaneously. Remember that. So some amount of PEEP is always given in COPD even after intubation. But the major role of PEEP, measurement of auto PEEP and everything, comes when doing weaning. In asthma, you can start with 0 PEEP when you initially intubated the patient. At the time of weaning, you can give a very slight amount of PEEP, mainly to help the trigger work of breathing. Okay. Coming to obesity. Obesity was one of the problems when we talked about poor chest wall compliance, poor abdominal compliance. Here the limiting plateau pressures to 30 can lead to hypoventilation and atelectasis in the dependent areas. So it is a transpulmonary pressure which should be targeted in these obese subset of patients. You can't just randomly or arbitrarily increase the plateau pressure to 35, 40, 45. No, that doesn't work that way. At the same time, the obese patients who are morbidly obese, they have there's small airway dysfunction also. They behave somewhat similar to COPDs. They have a small airway problems also, and the chest wall compliance is profoundly reduced. This will increase the intrapleural pressure and decrease the transpulmonary pressure at any given airway pressure. So just as I told you, those things are effectively, they can sustain higher thoracic pressures more better off, more alveolar pressures more better, because the transpulmonary pressure or the difference is still low. So the level of PEEP need to support it may be higher. They have two problems: poor chest wall compliance and again collapse of the smaller airways. So they need a higher amount of PEEP vis-a-vis a patient who is not obese. So for a patient who will start with a PEEP of 5, maybe you have to go up to 8 to 10 for an obese patient to get the same amount of oxygenation, same amount of ventilation. But the tidal volume should be according to ideal body weight. That doesn't change. Especially when you are going towards higher PEEP, you have to keep the tidal volume restricted. I told you that shortly before. The rule of thumb, PEEP can be set equal to the intra-abdominal pressure. This is with regards to PEEP. Any questions you have?